So Meconium Aspiration Syndrome is going to be one of those diseases in the newborn that can only happen in the term baby or the post-term baby. And most of the babies who are going to be born post-term, this is more than 42 weeks or 41 weeks inside, they are going to have Meconium Aspiration Syndrome. So let's look at this high yield condition, see how we can manage it, how we diagnose it, and then we shall be good to go. So Meconium Aspiration Syndrome is going to be a form of neonatal respiratory distress that is caused after aspiration. This is when we have something entering into the lungs that is not supposed to. And what is entering this side is going to be meconium-stained amniotic fluids during or immediately after birth, resulting into airway obstruction. Because this meconium is kind of thick, it's going to cause airway obstruction, and after that, the inflammation that is going to follow is going to cause issues, and it's going to also cause a dysfunction of the surfactant. Remember, surfactant is the thing that reduces the surface tension, and in the previous video I've talked about respiratory distress syndrome. This time we're going respiratory distress syndrome is what happens in preterms who have not yet produced surfactant. Meconium aspiration syndrome is going to cause surfactant to dysfunction. So let's look at how we can manage this condition. So the epidemiology is very important because it only occurs in term or post-term babies. Rarely do preterms go ahead and pass meconium. So 10 to 15% of deliveries end in this, and 5 to 10% of those go ahead and develop meconium aspiration syndrome. A higher mortality is very, very much found in limited resource limited settings. I'm from Uganda and I've seen this a lot of times, but it is not always so severe, and that is the good thing. So the pathophysiology, what happens stepwise is that we have fetal distress. The fetus is distressed while inside the maternal body or while inside the uterus, and when they're distressed, there is vagal stimulation, and vagal stimulation leads to passage of feces, which is going to be meconium. The first feces that are passed by a baby is called meconium. So that baby, while they're still inside the uterus, they always take their breaths. They always have like a breath or two every 30 minutes. So they're going to have gasping in utero, and when the gasping occurs, that first breath, there's going to be aspiration. They're going to swallow, they're going to pull that meconium within, and it enters the lungs. Now, when it enters the lungs, it's going to cause the mechanical obstruction first, whereby it may impact somewhere and air stops going to a particular part of the lungs, and that is going to cause that part of the lungs to collapse, which we call the complete obstruction that leads to atelectasis. Then sometimes we may have a partial obstruction that causes a ball valve effect. And what happens is that air is going to be able to get into the lungs because it's coming in with a higher pressure from outside. But when it enters, the meconium is going to close, and that air is going to be trapped inside there. And this is going to cause a hyperinflation. And if this occurs, we can have rupture, and the rupture is going to develop into a pneumothorax. Then we have chemical pneumonitis, which is going to be just inflammatory cytokines coming in because we have something that is not supposed to be in the lungs. In the lungs, cytokines are going to be released, and these cytokines are very violent. That inflammation is going to fight what's coming, and the lungs are going to be collateral damage, so we shall have lung injury. Sometimes we have the surfactant inactivation because of that meconium. Remember, surfactant is like a kind of lubricant that is making things good, and then this meconium reaches there and it makes the surfactant not to work, which is going to worsen the hypoxia. Persistent pulmonary hypertension of a newborn is something that is going to occur simply because we are having this newborn being on oxygen for a long time, and it's going to become because we have hypoxia, and the hypoxia causes pulmonary vasoconstriction. And when you have pulmonary vasoconstriction, the pulmonary vessels are going to have a high pressure, so the blood is going to be shunted away from the high pressure system into the low pressure system, which is a systemic saturation. So you develop a right to left shunt. So risk factors that we are going to have post-term pregnancy, that is pregnancy greater than 41 or 42 weeks. We can have fetal distress because once the baby is distressed, then they're going to they're going to be hypoxic, they're going to be acidotic, and then they're going to release meconium. Maternal conditions like hypertension, diabetes mellitus, smoking, all these things are likely to increase the likelihood of us having fetal distress. Oligohydramnios is also going to increase the risk of getting a fetal distress, and then prolonged labor, of course, is one of the consequences of is one thing that is going to cause the fetal distress. So the clinical features that we have at birth, we have meconium-stained fluid. Once you see this, then you should start suspecting that we could have meconium aspiration. A depressed neonate, that is a neonate with a low upgas tower, then you should also suspect that they could have meconium aspiration syndrome. If they develop respiratory signs, that is tachypnea, that is the grunting, which is like the natural CPAP. The baby is trying to create a natural CPAP for themselves. They're trying to make the airway have a positive pressure. If you do not understand what CPAP is, or continuous positive airway pressure, I made a video about this. Please go and look at it. Nasal flaring, chest retractions, and cyanosis. Then severe disease is going to be presenting with a barrow chest. This is because air has been trapped. The meconium is not letting air get out of the lungs. We can have signs of persistent pulmonary hypertension of the newborn, and then pre and post ductal saturation difference. This is between the blood that is between the ductus and before that, and then you'll find that they have a different SpO2 or oxygen saturation. The diagnosis is going to be clinical as well as history. If someone has meconium aspiration or meconium-stained aspiration, meconium-stained fluid and respiratory distress, and they are a term baby, then we most likely have meconium aspiration syndrome. On imaging, what you're going to see is going to be patchy infiltrates. Unlike RDS or respiratory distress syndrome, where you have a ground glass, this time we have a patchy infiltrates. We're going to have hyperinflation. We can have areas of atelectasis, and sometimes we go ahead and have air leaks or pneumothorax, because as air is trapped, it can rupture through the lung and then it enters into the pleural space, and we have a pneumothorax, which can turn into a tension pneumothorax, which can eventually lead to death. So the differential diagnosis, we have transient tachypnea of the newborn, we have respiratory distress syndrome, we have neonatal pneumonia, we have persistent pulmonary hypertension of the newborn. So when we look at the management at delivery, this is a critical change in the guidelines. We don't want to do routine vigorous suctioning. This is because the suctioning has found to cause vagal stimulation that lowers the heart rate, which is not good when you're actually resuscitating a newborn. If non-vigorous and they have poor tone, heart rate less than 100, or they have apnea, please begin the resuscitation protocol. Resuscitate this baby and consider airway support. If they are not improving, so we no longer do the routine intubation to suction. Long ago they used to intubate this baby and then a suction would be put to try and suck out the meconium. Studies have shown that this does not improve any way in the care. Supportive care is the mainstay. Oxygen therapy, that is going to be to maintain an SpO2 of 90 to 95%, and then ventilatory support is important. CPAP for mild to moderate, and then mechanical ventilation when things are not improving. Surfactant therapy for severe meconium aspiration can be done, because we have seen that meconium aspiration can also disrupt the working of the surfactant that is in the lungs. Antibiotics are very important due to an overlap with pneumonia. Many kids who develop meconium aspiration syndrome actually go ahead and develop a pneumonia, so giving antibiotics is going to be important. Manage the persistent pulmonary hypertension with inhaled nitric oxide, or sometimes use sildenafil in the low resource settings, because these drugs help relax the pulmonary vessels, and that will help with the shunting. So some of the complications of this is going to be air leaks, because that hyperinflation, sometimes we have rupture and pneumothorax will occur. We can sometimes have the air entering to the mediastinum and we have pneumomediastinum. We can have persistent hypoxemia, persistent pulmonary hypertension of a newborn, secondary infection, and long term we can have reactive airway diseases like asthma developing. So prognosis, must recover within 2 to 4 days. In severe cases, there's prolonged ventilation, and then mortality has decreased with modern care, of course. Prevention is going to be good intrapartum monitoring, timely delivery in post-term pregnancies. Don't let that pregnancy go for a very long time, and then avoid fetal hypoxia. So what do you need to know that is very high yield? Term Upper stem babies plus meconium plus respiratory distress is basically what we call the Meconium Aspiration Syndrome. The pathology is because of obstruction, inflammation, and surfactant failure. On X-ray, you're going to see patchy infiltrates plus hyperinflation. The main complication is going to be persistent pulmonary hypertension of the newborn. And the management strategy is supportive with oxygen, CPAP, or ventilation. And one important thing known to do is the routine vigorous suctioning in neonates, especially in the vigorous neonates. Do not go ahead and over suction them. So we have come to the end of this video. My name is Benjamin. I hope you enjoyed the video. If you have not subscribed to the channel, make sure you subscribe so that you don't miss out on any of our high yield videos.